Good afternoon, everybody. My name is Sawa Nakagawa. I'm the chair of the Demand Side Working Group at the Impact Investing in South Africa. Warm welcome to everybody. It's really you're in for a treat today. We've been discussing in the Demand Side Working Group a variety of different challenges that social enterprises and entrepreneurs face in the country in terms of accessing financing in the past few years. Today, we're doing something quite different. In the past, we were quite in a silo mentality, so to speak, discussing demand side challenges, supply side challenges. And today, what we're going to do is this is really the first of hopefully a series of discussions where we're going to focus on particular sectors and have a number of very experienced speakers who will share with us key challenges and for us to really have concrete conversations about how we can resolve some of these demand side and supply side issues together. So before we start, I just want to thank all the speakers who have made themselves available, as well as our fantastic moderator, and to Shiluba and Misha from the Bertha Center who have worked tirelessly in the background to pull this off. So thank you so much. And we look forward to hearing from all of you about how these conversations are going to go and improve them, and look forward to this afternoon together. So I'm going to hand it over to you, Pascal.
Thank you so much, Sarah. And good afternoon and welcome to the workshop on impact investing in health in South Africa. Thanks for the organizers for putting this together and for inviting me as your moderator. My name is Pascal Freudicher. I currently run a family office in a small country called Liechtenstein, and I had the opportunity to look at impact investing from many different angles. So I was an advisor to impact investors and ran a small incubator in Cape Town. I had the opportunity to run my own impact business in the healthcare space in Johannesburg, and was also involved in lecturing in South Africa as well as in the US. I now can see it, the whole thing, as an investor, from an investor's perspective, which is obviously changes the perspective once more. In the last couple of months, obviously, healthcare has been in the news through the topic of the COVID-19 pandemic and has shown us how critical the health sector is for society and the economy, and that it can't be seen as a silo that's far away from the rest of the economy, but that we're in the middle of it, irrespective of what business we're actually running. When we're looking for investors for my former business in 2018-19, which was an early stage company in the healthcare space in Johannesburg, there were very few investors that had an explicit interest in healthcare companies. And for a good reason. Healthcare is a very complex industry. It's dominated by government. It has very complex corporate and professional interest in this, but this is changing. So there's very growing interest that I've seen in South Africa and all over the world in healthcare businesses. If you look at venture capital websites, that has changed. Healthcare is all over it. So I think that's a very interesting development that we're experiencing right now and that we can discuss today. Healthcare is and will remain, though, in the public domain. It's critical for investors and entrepreneurs and intermediaries to understand the role of the state and its priorities in the field of health. So I would argue that's much more important in healthcare than it is in many other industries. This is particularly true when government is fundamentally changing its involvement in the space, like it's happening right now in South Africa with the national health insurance. In the health sector, we talk about lives. We talk about human lives, which is obviously our most precious asset as a collective humanity. This means we can generate most meaningful impact, which is longer and more healthy lives, by investing into that sector. However, we need to make sure we keep in mind whose lives we're positively impacting with our investments and business models and whose life we're not. So real impact is often created where people cannot pay for services. This is obviously one of the difficulties in impact investing within the healthcare space. Today, we have a very rare opportunity. I've never seen anything like that, where stakeholders come together from demand and supply side to really discuss and figure out how to bring that sector forward and how to solve the issues that we're having in front of us. And I'm sure I've touched on some of them, and I'm sure there will be many more raised within the afternoon. Quickly on housekeeping, I would ask all participants to keep your microphone muted if you're not speaking, and keep the video on so that we have as close to live experience as possible. You'll have the opportunity to share in the breakaway room. So we will have in the plenary, it will mainly be speakers talking. We'll have at the end a session of reporting back that will be a bit more interactive, but the first part, please let the speakers speak. That doesn't mean that the session won't be interactive. That interactive part will come and you will have plenty of possibility to share. So let's go into the outline of the day. Thanks, Precious, for putting up the slide. We're in the first part, welcome and introductions, which we're ending in the next 30 seconds. Then I will hand over to J.M. Tucker from the Clinton Health Access Initiative. Then we will have two speakers from the demand side, challenges, two very experienced entrepreneurs, and I'm very happy that both could make it today. Then two speakers on the supply side for supply side constraints. Then we have a breakaway room discussions where we have plenty of opportunity to share and to come out with solutions that we can put together at the end when we do the report back, and obviously then the next steps. Very much looking forward to this discussion. And I would ask you to please have the next steps in mind as you go through this. So when we hang up at the end and put that red leave meeting button at the bottom right at the end of the afternoon, I want us to have some kind of plan in mind what's happening next, because it would be nice to not just talk, but to talk and have a concrete follow-up, that we have a fantastic organization in the background that can make things happen. So please think about that while we're going through the session. What are potential steps? What would the sector really benefit from as you go through the afternoon? So I would now like to hand over to the Senior Technical Advisor for Sustainable Health Financing at CHAI, which is the Clinton Health Access Initiative, and J.M. Tucker to set the context. Thank you very much.
Thanks, Pascal. So just to tell you a little bit about myself, I'm a development economist by training. I've worked in Southern and East Africa for many years, as well as South America and the Caribbean. And my background is not in investment. It is in health policy and systems, with particular focus on health financing and service delivery. And so I'm not going to talk, and I'll keep my comments brief because I think the main interest is going to come from the presentations. But I think the context of NHI is one that's very relevant right now. I hadn't heard about impact investing until a couple of weeks ago, and I started looking and reading more about it. And I think what stood out for me first and foremost is the fact that there's a recognition now of a particular category of investors who have a desire to go beyond just responsible or sustainable investing and actively create high impact solutions, and that these are investors that really have a longer term or a broader view of investment than is traditional, and may be willing to accept possibly even lower than market financial returns in order to create greater societal returns defined against certain parameters. And my understanding of the objective of today's healthcare financing session is to have a strategic discussion that looks at, first of all, just more generally where there are opportunities available in the health sector for any investor, which means alignment of the supply and demand side. Second, to understand the nature of existing obstacles that are there and ways that we can overcome them. But I think thirdly, and most importantly, or as importantly, to understand how and why the health sector reflects a valuable investment opportunity for this particular category of impact investors, defining what is the social return that can be expected and the scale and scope for investment there. I think that in this respect, the timing for this meeting could not be better insofar as South African government has committed to SDG 3.8, which is universal health coverage, or UHC. So just as a quick reminder for anyone who's not clear, UHC is about creating a health system that sustainably delivers quality healthcare services to all persons based on their level of need, and therefore providing for financial risk protection. So it's firmly grounded in a human rights context, as well as a lot of economic literature. And in South Africa, obviously, our strategy towards UHC is National Health Insurance, or NHI. And I've heard over the years, many people ask about why government eventually settled on an NHI model and not a NHS or a social health insurance model. And the reason is that as a funding model itself, NHI is best placed to address what is arguably the most salient characteristic of South African society and economy today, and that's inequality. And I think it gets to the point that Pascal was raising about we're actually not just interested in what services are delivered, but who is getting those services, who is being impacted. So I think for any impact investor for whom improvement in equity is of interest, this really is not just a relevant investment opportunity, but a timely one. I thought just to touch before I go on just the two ways in which NHI is trying to address inequality as the context for this group of investors. The first is through pooling of funding, which allows for the risk cross-subsidization from rich to poor, healthy to sick, young to old. And it means that together with the planned patient level data, we have a means of linking the supply of healthcare to where the need is most urgent and addressing inequality in that way. The second is that NHI would for the first time provide for an explicitly defined set of healthcare benefits to which all persons are entitled, and access with that patient level data can be measured. Now, what the evidence shows internationally is where you have a health benefits package that's not explicitly defined, there tends to be implicit rationing, which affects the poor, the marginalized more. And so that's why this is a particularly important element. You'll see that NHI does not typically talk about healthcare services, but healthcare benefits. The terminology is not by chance. It's chosen to highlight that the unit of measurement that is of interest today is outcomes and impact, which is what I think this group is interested in. In a context of value-based care, patient-centered care, we're less interested in the number of services delivered, measured through resources expended, utilization figures, and more interested in the resulting outcomes and impact. And this means outcomes for an individual and the impact that has on their household, their community, but also the outcomes for at a population level and the impact that this has on society and the economy more broadly. It's reflected in the shift in the language of value for money to value for health and what that health buys your society and economy. And this is why there's work underway to build a national healthcare benefits registry and information system that would define and track healthcare benefits. And that would be a critical element of governance, the governance framework for service delivery, and a foundation for what in the NHI world they tend to talk of as strategic purchasing. And I think what essentially equates amongst this audience to impact purchasing. So maybe just a last point to say, while NHI is obviously the best fit from a funding model perspective, it also necessitates what we're seeing now is a restructuring in service delivery models. We're shifting from what's been two parallel public and private health systems to a unified one. And this requires alignment of public and private sector service delivery to reflect global best practice, but also testing new and innovative ways and models of service delivery that bring us the greatest value for health in the South African setting today. So I'm aware that I'm not going to go into any of the details of demand supply side. I think there are people far more well prepared and well experienced to talk on that. And I'm aware I've probably gone over my 5 minutes, but I do hope that this provides at least some context for the discussions today and highlights not just the relevance, but the timeliness of this meeting. And for that, I must thank the organizers of this session. So thank you.
Thank you so much, Jim. Thanks for these clarifying inputs. I think it really helps to put things into perspective. I know, Alan, you're a bit tight on time, so I don't want to delay this longer. So I would like to go directly into the demand side challenges and introduce Alan, Alan Swaden, who's a registered clinical psychologist and entrepreneur. I had the pleasure of meeting him a couple of years back and always enjoyed his guidance and appreciate his guidance on my own entrepreneurial ventures. He founded the Akeso Group and was the CEO of it, which is a group of psychiatric hospitals, which he sold to Netcare in 2018. So I think he will have a very specific perspective on demand side challenges through to that exit as well. Alan, the floor is yours.
Thank you very much. Okay. So yeah, thanks very much, Pascal. It's nice to see you again. I haven't seen you for a while, and thank you very much for the invitation. I have not really had much of an opportunity to understand what this forum is and what you guys are really interested in. So I hope that what I will talk about will be of relevance. So yeah, I'm a clinical psychologist. I have got an undergraduate degree in commerce. And in 2008, I recognized that there was a real need for psychiatric hospitals in South Africa. With a friend of mine who had some much more commercial experience than me, we started the Kesso Clinic Group. We started with one hospital in 2008 with 50 beds. And what we did was we built a model of integrated care. The difference between a psychiatric hospital and a general hospital is that in a psychiatric hospital, patients are walking around. And so you can't have a fee-for-service model in and of itself doesn't really work. So although we build on a fee-for-service model, we created this integrated structure between the hospital, the nursing, the psychiatrists, and all the allied services. And that made life easier for the psychiatrists because they didn't have to manage every aspect of their patient's stay. And it actually, I think, really improved patient care for the patient, who now has some kind of structured program to work through with some kind of guidance in terms of what kind of goals we were trying to achieve. Between 2008 and 2016, we bought 4 more psychiatric hospitals, and we put our model onto those hospitals where they were relevant, and we built 8 new hospitals. And at the end, we had 892 beds in 13 sites. And as Pascal said, we sold to Netcare in July 2016 was when the deal actually was made. But it took almost 2 years to get it through the Competitions Commission and then the tribunal, which I'll touch on a little bit later. I think that there are lots of opportunities in South Africa. There is a huge unmet need in lots of areas, and I think especially as a consequence of COVID, where I think literally tens, if not hundreds of thousands of operations would have been put off because people have been scared to go into hospitals, or hospitals have been closed, or doctors have not been available. So I think that where there was, in some ways, perhaps a meeting in the private healthcare system between supply and demand in some areas, I think that has really shifted. And I think that the unmet need and the demand will be massive once things return to normal within the private healthcare sector. I'm not sure how it's going to work out in the public sector. There's a growing mental health epidemic. I think everybody speaks about it. It's not only in South Africa, but it's worldwide. People are more isolated than ever, and traditional models of offering psychiatric or mental health care are just not working. They're not meeting the need. We have an aging population, as everybody knows, and that comes with its own opportunities as to really care for people. People are living longer, and but interestingly enough, they're getting dementia and memory loss at the same age. So people are living longer and sicker lives, unfortunately, in a lot of instances. But there is an aging population, which creates both problems and opportunities. We have a very fragmented healthcare system in South Africa, as I'm sure people have spoken about or heard about before, where you have the funders on the one side, and you have the regulator being the government on the other side, and you have the providers of care, and the providers of care don't really speak to each other. So you have this very fragmented healthcare system, which drives up costs, creates inefficiencies, and doesn't allow for big data sharing. So we have a lack of data-driven care in South Africa, because the only people that have all the data really are the schemes and the administrators, and providers of care, and I'll touch on this in a minute, don't really have an opportunity to really understand what data-driven or outcomes-based care would mean, other than in theory. But what I have found is that there is lots of interest from investors in healthcare if you can find the right opportunity. So I think that cash is out there and interest is there. It's just about finding something that can be sustainable and then scalable to make the biggest impact. Other opportunities, very briefly, is that in South Africa, we have 3 major funders. You've got let me go back here for a second. In South Africa, we have institutional funders of care, which are the medical aid schemes and the administrators. And what they really want to do, what medical aids really are asking for a lot of the time, in my experience, is they want to pass on risk. They want to manage their risk much better. They want to know if the pool of members is this amount of members, and we understand that in terms of epidemiology, these are going to be the issues that our membership are going to face during the year. How do we manage our risk in terms of outcomes and in terms of utilizations? The way to do that would be, the only people that can really take on that risk are the healthcare providers, which are in the bigger scheme of things, hospitals, doctors, and big pharma. And they need to find a way to drive down costs while improving outcomes. And the way to do that is to get into some kind of alternative reimbursement model. Providers are the only ones who can really drive down costs, although we have seen a lot of pressure being providers from the insurers and from the administrators to really drive down inflationary increases and to really try and manage utilization. The only people who can really make a difference on the ground are the providers of care. The insurers can't make a difference. They can put in protocols and they can put in some kind of risk and reward things, but they can't really manage the care. The providers are the only ones who can manage the care. And one of the other opportunities, I think, and it's also a challenge, is that in order to move away from these traditional payment methods, in South Africa, we have the fee-for-service model, which really is, I think, a very inefficient model. But in order to move away from that and towards alternative reimbursement models, providers do require commercial support. They need to be able to collect big data. They need to have negotiation skills with legal skills and financial skills. And they also need to corporatize. They need to have systems and processes in order to take risk. Other quick opportunities as advances in technology to better monitor patients. You're seeing a lot of it from Netcare, who are trying to drive down the cost of nursing by really having a digital strategy to try and drive down the costs of care overall. And then you've got really great initiatives like Curo, which is a hospital at home model where you can be at home for most of the medical inpatient care, not surgical obviously, but for medical inpatient care, and they can monitor you remotely. And I think that could also be a wonderful opportunity. So technology can help. I think that if people integrate and share information, I think you could avoid wastage. And in South Africa, we don't really have an opportunity to really understand what our protocols are because of the fragmentation of care, but there are internationally accepted protocols where you can bring in protocols that would help the hospitals, pharmacies, and doctors to understand what they need to do to create best outcomes at the lowest cost. And the last opportunity I'll talk about is care coordination. In South Africa, again, we have a real issue around scope of practice. The easiest example is a child that develops a rash or a cough, and you take that child off to the pediatrician instead of taking that child off to a clinic where they would be treated first by a nurse, then maybe by a GP, and then maybe by a pediatrician. A lot of us go straight to the pediatrician. And what you find happening in South Africa is a lot of professionals are working at the bottom end of their scope of practice instead of at the top end of the scope of practice. And the only way to change that is to have proper care pathways and care coordination, which we don't have in this country. So I think those are all things that create opportunities. The challenges that we have, and as someone who really does try and invest and start new businesses in South Africa, is that we have three major funders. We have government, we have the medical aids, and we have private paying patients out of pocket. It's very difficult to do business with government for lots of reasons, but primarily because of the uncertainty around NHI. There's not a lot of information out there. Governments are traditionally poor payers. And I think that for people to really develop a plan, I've seen a couple of people who are really well qualified not be able to succeed with their plans because working with government is just so difficult. The second thing is that medical aids, who are another massive funder of private care, their membership is not growing, and a lot of members are buying down. So they're moving away from a risk and savings plan into mostly risk and only a little bit of savings. And that creates issues around solvency for the medical schemes. And so they put a lot of pressure that they're feeling downwards onto the providers in terms of price and utilization, which I touched on a second ago. Another real challenge is that the medical schemes are the only ones who have a patient-centric view of what happens around procedures. They're the only ones who collect all the information, and it's all billing information. It's not quality information or outcomes information. A lot of it is just billing information. But even so, the fact is that it's actually very limited what information they have. They have the best information out there. Providers don't have a mechanism to really share what is happening between the surgery, the post-operative care, the physiotherapist, whatever it might be. People do not share in a systemic way all their information. And that creates a very difficult situation in terms of taking on risk as a group per procedure. And then the other challenge that I'll speak about on this page is that there's not a lot of money for out-of-pocket funding. A global billing, let's say somebody wants to go in to have a knee operation and they want to pay out of pocket, they'd have to pay the hospital, they have to pay the surgeon, they have to pay the pharmacy, they have to pay the doctors afterwards. It becomes a very complex situation, and global billing is a very difficult thing to manage overall. I've spoken about the fragmentation, and there's no patient-centric view. The Health Professions Council make it very difficult to integrate healthcare because they don't allow multidisciplinary practices. So you can't have a physiotherapist and a surgeon working together to take risks because they can't develop a practice together. The Health Professions Council don't allow employment professionals. So it makes it very, very difficult to try and drive down prices and improve quality through employment. Collective bargaining, it's very difficult. The Competition Commission keep a very tight, very watchful eye on any kind of bargaining that might be seen as being collective. So you have, it just doesn't happen really, unless it's really big groups negotiating with big schemes. The medical schemes have a very short-term view. They have a 12-month view. Even though they talk about long-term and population management, they really work within a 12-month structure. So it's very hard for them to take risk of paying for something now that might save money down the road because those members might leave. So medical aid administrators, I have found, don't take a lot of risk, although they talk about it. The competition or tribunal don't want to see concentration of ownership, and it's very difficult for a niche hospital group to be sustainable, for one hospital to be sustainable and to grow without becoming part of a bigger corporate for the stuff that I've mentioned earlier. And that's it. I'm sorry, I raced through everything, but I wanted to try and give the best overview that I possibly could of my own experience in the healthcare environment.
Thanks so much, Alan. This is really so much very valuable information that's not just out there. I hope you really listened to this, because this is really the problems of the private healthcare sector in South Africa, and the issues of why it's difficult to actually create and run and grow businesses in this space in a very condensed and I think very, very well presented manner. Thanks so much, Alan. This is really, really appreciated that you share your experience with us.
Sure.
I will pass on to the next speaker from the demand side, which is Saul Cornick. He's looking a bit on a different side of the healthcare system, but also on the provider level. So I think it's a nice complementary. He has a varied background, ranging from healthcare to technology to finance to machine learning and to culture change. He co-founded and is the CEO of HealthForce, which is an augmentation of technology and doctors that turns nurse-led clinics into effective and specialist health centers. I had the privilege to see his technology live. I was in his office. Now he showed it to me, and I have to say I was quite impressed with what he showed me years ago. So I'm sure that now it's on a completely different level. So I'm very looking forward to hearing Saul's comments as well. Thank you.
So it's just saying, thanks very much for the introduction, Pascal. Yeah, we've been hard at work. Our technology is evolving. As it's good to see you again as well. I haven't seen you since you left South Africa. Yeah, I'm the CEO and co-founder of HealthForce, and I'm going to talk today mainly about the funding challenges that we've experienced as a health technology company trying to raise money for our nascent startup to what is now turning out to be a slightly bigger business. We're certainly at the stage of Adam, who's managed to sell the business, but I'll get into that a little bit later. Let me just start off by telling you a little bit about HealthForce. We've taken, first of all, I must say I agree with everything that Adam has said. Unfortunately, he raced through a lot of very valuable content very quickly, and I'm hoping that the non-healthcare people managed to track some of that. I will reference some of what he said as I'm talking. What HealthForce has done is taken, I suppose, an opposite approach to him, where he started building a hospital business, trying to treat people at that secondary and tertiary level, trying to create integrated care at that level. We're trying to do the same thing, but at the entry point into the healthcare system. So we've got the same view that you need to have care coordination from the lowest cost, lowest trained skill, referring up to the most highly trained skill only as needed. And in that way, not only do you lower cost because the lowest cost resource is treating you when you need it, but you also improve health outcomes. And the strange thing about healthcare as a good, it is not a normal good, it is a social good. It is one of these strange things where the more you pay at a systemic level, the less you get. And the classic example of that is cesarean sections. You have obstetricians leading antenatal care. You have an 80% cesarean section rate at much higher cost and at much higher risk to mother and child. Whereas when you have a primary care-led birthing antenatal care with midwives, you have much lower cost and you only have a 20% cesarean section rate. So that's the kind of classic example. What HealthForce is trying to do is try to set up the nurses as a low-cost entry point into the healthcare system and to bring the more specialized skills into the clinic room through technology. First allowing the nurse to do top of scope, and then allowing the nurse to access those skills as and when needed. And we started out in a small group of pharmacies called Medicare. We were doing a few consultations, and nurses were capturing the consultations on HealthForce. and accessing our remote doctors through our technology. And we've grown from there to 450 clinics around the country. We've done over 1 million nurse consultations in our system. We've done well in excess of 110,000 doctor consultations. And it's been a real journey to get there because we are still not profitable. We are still building towards profitability. And this speaks to some of the funding challenges I'm going to talk to now. So the first funding challenge from our side is this healthcare system value chain challenge that I often think about. And the reality, as I mentioned, healthcare is very complex and it's not a normal good. And the problem with trying to raise money for the kind of thing that Healthforce is doing, where you have to understand the complexities of the healthcare system, is that investors don't often understand the healthcare system, and they take the normal good view of healthcare. The more you pay, the more you should get, and they're trying to apply that to the model that you're trying to bring to have funded. And sometimes on the other side, on the demand side, tech providers may find simple, innovative solutions to problems that they think should obviously be implemented, but they miss the boat on the social aspects of how they embed that technology solution in the product, in the value chain. There's also, because there's this complexity in the system and because there's this fragmentation that Alan was talking about, there's also no standardization in the healthcare system. And that means it's very hard to take one piece of technology and generalize it across the whole healthcare system. Either you've got to make it so general that it doesn't really do anything, or you've got to try and bring standardization to a system that doesn't work together. Healthcare, it's very hard to therefore build something that can scale, and investors quickly pick that up. And then finally, on this value chain challenge, I must say that it's very difficult to break into that value chain because that value chain, that workflow is locked up. In South Africa, it's locked up in the private sector by 7 companies. The 2 administrators, Discovery and MedScheme, by the 2 pharmacy groups, Clicks and Dis-Chem, and by the 3 big hospital groups. Really, there's nothing that happens in healthcare outside of those 7 companies. And so no matter how good your technology is, you may not be the lowest marginal cost implementation for this narrow segment that you're trying to get into. And as a result, you get excluded from the system, no matter how amazing your technology is. And so investors coming into the healthcare system want to see you scale to these big providers and are funding you to do so, but those big providers lock you out because the value chain is captured. And your solution may on its own be valuable, but in terms of the rest of the value generated throughout, it's such a marginal thing to them, it's not worth them making the investment to change the way they do things. So that's the first challenge to fundraising in the space, is this value chain challenge. The second big challenge that I found we faced when we were trying to raise to grow our business is this corporate venture capital challenge. And it speaks to this idea that the value chain is locked up by 6 or 7 big corporates in South Africa. What we found was, as soon as we started doing something valuable, the big corporates came to us and they wanted to buy us. And that might seem enticing, right? You've got this big company, listed company, wanting to invest money in you, buy you. Why is this not a good thing? Well, it's a real challenge for 2 reasons. First of all, because often they're trying to buy you for their own purposes. And the reason I'm doing Healthforce, yeah, of course, I'm trying to run a business, but there's a real strong purpose behind what we're doing here. And each of those approaches by corporate venture capital would have either undermined our purpose or it would have reduced our impact in some way. And the 2 are linked. In other words, it would have been transformed into what that hospital wanted, into what that funder wanted, in such a way that the reason that we're building Healthforce would have been completely destroyed, to be honest. And the value that we think we could bring to the world through this teamwork where the lowest cost skill can treat you would have been lost. And so the options were as follows. Either we get bought by these big corporates and lose our sense of identity, or we go it alone. And by going it alone, it leaves us susceptible to one of 2 things. Either the corporates do it themselves because they've got the cash reserves and they've got the value chain to do so. And literally corporates looked us in the eye sometimes and said, yeah, we're just going to build what you've got if you don't sell to us. And the second thing that you're susceptible to then is that they acquire a competitor and fund that competitor to take you out of the market. So you're really caught between a rock and a hard place in the South African market, these big corporates and this corporate venture capital that comes along, trying to pick up the pieces where you can offer something of value to the value chain that they own. And then the third big challenge is, trying to raise sufficiently large funding to walk the long road in health tech. And I love this image. It's an image of the this kind of one shoe or the other shoe. Which foot are you going to be walking on here? And the big issue here is again around the value chain and competing with incumbents. And that the reality is that in order to build something in the technology space, given that the value chain is so locked up, you really need to invest a huge amount of money to get the scale, to get the volume, to get the experience, to get the data that you need to get yourself to the point where you can be profitable. And what we found was when we came to South African venture capital companies, the first question they asked was, let me see your pathway to revenue. Whereas when I went to European and US investors, they wanted to see my pathway to data. They wanted to see my pathway to volumes of patients. They literally said to me, we don't care about the revenue. If we can capture the value chain, no matter how much money we lose along the way, given the size of the market, we know we'll make that up. And so there was this very different approach in South Africa compared to the Europe and US in venture capital outside of the corporates, where South Africans wanted us to walk in the dirty, broken shoe for trying to scrape our way along a marathon to the end, where we could finally turn something into, cash flow positive, whereas the international venture capitalists were willing to invest in something that was of high quality, that could allow us to build the value that gets created, value that's not determined by revenue. And so what ended up happening with Healthforce at the end of the story is we ended up going the corporate venture capital route, but we went with a partner we actually went both routes. We went with a partner who had a very strong strategic alignment with what we wanted to do. And that's Dis-Chem. They really see the healthcare system in the same way we do. And so they've made a big investment into Healthforce. And then the second thing we've done is we've raised from a Swedish venture capital fund for a new product that we're going to be launching. And these guys are not looking at revenue. They're very happy for us to build this product out over many, many years to capture the market and generate value in measured in other terms. So that's all from me, Pascal.
Fantastic. So I really appreciate that succinct presentation based on three main and very accurate challenges. I have to say I know all of them very well from personal experience, so I can really relate to what you've been presenting. Thanks so much. And I think this little nugget of value for all entrepreneurs with the South African versus overseas investor is really useful to know that upfront. I wasn't aware of that at the time, and I think it could have been useful for me to know. So thanks, Saul, for sharing that little nugget of wisdom. So we're gonna go to the supply side constraints now. And we have two speakers. The first one is Quinton Zunga, who is the founder and current CEO of RH Managers. RH Managers is a private equity firm investing in healthcare infrastructure and providing accessible and affordable quality healthcare to the greater population of South Africa. So I'm really looking forward to hearing the supply side constraint. I know the demand side quite well. I'm really curious to see what the supply side is going to say. So Quinton, the floor is yours. Thanks so much for being here.
Hi, how are you doing? Hopefully everyone can see it. I want to share as well, just to give you a summary of what RH Managers is all about. We are a collection of private equity funds, 4 of them, a debt fund, 1.3 billion, which is probably now $100 million, 2 specific private equity funds, about $100 million each, and a listed permanent capital vehicle, which is about $30 million, 30 to 50, it fluctuates with the share price. So we are a healthcare investor. A lot of us see us as a healthcare company, but we're actually not, which is for a specific reason, which I think was alluded by some of the speakers. So I want to talk about the infrastructure side, because there's the service interfaces with the infrastructure. And what you see is that if the infrastructure is not efficient, it impacts the service. So everything that we're talking about lands up with someone in a facility taking medication, as well as staying in a hospital bed And that interface is where I think the market has a lot of challenges, especially in South Africa, where the regulators are more in separating infrastructure, funding, and related services. So they don't want to see a holistic view, which creates a very inefficient state of the disunion, if I call it state of disunion. So what are we doing? So because of this challenge, we are investing in an ecosystem. And we use the word ecosystem very smartly because we are not primarily looking at a shareholding, but we're looking at the value chain, because we realize that to invest in the infrastructure as a new entrant, I think the first speaker mentioned it, that it is a mammoth task. You are starting from ground with pretty much concentrated players, and you need the scale. I think Saul, you say that you need the scale to get the efficiency, the data to be profitable. And the South African market is not very appreciative of that lead time. Everybody wants to kind of get you profitable, and it's very difficult to create the scale. So you find that the bigger groups are getting bigger, and the smaller groups are just fumbling all over the place, and it's a movie that repeats itself. And then all of a sudden, the government sees there's so much concentrated power, they try and change the rules of the game. But ultimately, our view that whether you're going to go NHI model, private model, infrastructure is going to underpin efficiency. It has to underpin efficiency. What we see is that private sector is generally more efficient in bringing infrastructure, but not that anymore. I mean, we work with the bigger groups, and they're not as efficient as they could be because they are not expanding at the rate they should be. Then government obviously is off the chart in inefficiency. So you look at infrastructure that if you take all the private sector bed and public sector bed and you want to give a fair service to everyone, you've got an infrastructure problem, right? And I think that is kind of the one of the two big elephants in the room with NHI is how do you fund it and what infrastructure do you use? Because at an equated service, you're going to have to figure out what benefits make possible. So we are trying to do ground up, which is invest in the players that create an ecosystem, but push them to a point of efficiency. Because when there's efficient, they will get to profitability. If you're building, just to give you a sense, when we started investing, we were investing and building infrastructure at hospital acute beds at 2.5 million rand a bed. That was 6 years ago. The rest of the market has gone up the curve to about 3.5. Government is building at 5 to 6 million rand a bed. We are now building facilities at 1 million rand a bed because there was just no way the model would work with an ever increasing infrastructure cost. So what we have is a fund management, which is basically infrastructure related, which creates the infrastructure. Then we invest in the operators who actually utilize the infrastructure, but coming from an efficiency platform. Then we invest in the ecosystem for the clients to access the infrastructure, because if you build a hospital, the next thing is who's going to use it, right? And it's not a natural progression that the hospital works because it's in a place where there's high population. In fact, we've seen instances where patients pass our hospital to travel another 50 kilometers to another hospital because that's just how the DSP is arranged, which is ridiculous if you ask anyone who's who's looking outside, like the cost of going that far. But the point of equilibrium is such an inefficient place because of everyone trying to create value that you can't actually use all the pieces as is. You got to create a new thing. And yes, it will take time. And yes, you got to have patient capital, and that's where the problem is. So with all intent, the regulations have created a little bit of a conundrum, especially for the investment community that is generally skeptical about this very heavily related industry. So our view is invest across the board and allow the efficient players to integrate themselves, almost creating a new normal. And over time, the new normal should win. I mean, obviously, we're not yet there, but that is the business case, that over 5 to 10 years of efficient operations, you will start to give a model that will compete with the existing equilibrium. So that's how we're structured. We got a couple of different funds. We got investment in the operators. We got investment in the access products. We've invested in 35 hospital facilities, 20 medical centers, as well as the rest, which you can see public sector efficiency stuff. So what are the challenges? The challenge is, obviously, the first big challenge is that there's lack of healthcare investment equity. So the equity in South Africa is quite healthcare shy, and specifically because of the market risk, which I'll talk about, in that they're used to building a building with A-grade tenants, and then you go to the bank, right? Or building a power plant with a 20-year PPA with a government guarantee, and wow, that's a great product. Then you build a hospital, you have to depend with funders who are taking care of themselves. You have to deal with the regulator who just sees everyone is a little bit out of sync. So the equity pulls out. So consequently, no one is building much new infrastructure in South Africa. Number two, even the government is not building infrastructure because it just does it so badly, and it does it 1 or 2 times, and at exorbitant multi-billion everything, which is a bit difficult to put in a lot of infrastructure. So the equity to actually get this is off the ground. So you actually have to get a nimble entrepreneurs who really fight the system with like-minded, collation of capital, and your stories become 1 in 100, whilst it could have been 1 in 10 in terms of success, and that's where. Then the second problem is, obviously you got concentrated power in a few players, which is actually, if you ask me, the regulations for it. If you look at the funders in South Africa, you got 1 or 2 who nearly control everything. So if they don't like you, you got a big problem, right? And as you probably may be aware, if you're in South Africa, the infrastructure gets paid last. So it's quite a very destructive system, because you build a hospital over 2 years, fund it another 2 years before you get your first patient, you provide all the service, and then you bill after providing all the service, and then the service provider says, oh, actually, I don't like 1, 2, 3, 4, 5. And by the way, I've got a 60-day payment cycle. So it is phenomenally absurd, but that's what it is. And now you got big players, when they say no across the whole market. And the competition committee has tried to break this up, but it's difficult to break it up because there is a point of equilibrium already set. So I don't know. I mean, that's what we're trying to do by inciting smaller players to work within an efficient capsule. Then no integration. I won't say much, because I think it's been said before that everyone is working in silos, and the silos are inefficient, and it just creates another problem. No market, the market risk. So I mean, you won't be able to, I mean, it will be easier if the government say to the private sector, build me this, I use it at this price. Fantastic. It's not there, right? In South Africa, we've got clusters of provinces that everyone is doing what they want. Now the new entrants don't have the experience, they don't have the capital, they don't have the market regulations on their side. You can imagine what it is. Then obviously the infrastructure is most complex and requires very long-term view. I mean, I just gave you a cycle. That's an efficient hospital that takes 2 years planning, 2 years building, 2 years to ramp up. That's like, wow, this is great. It almost sounds like 3 years planning, two years building, 8 to 10 years to break even. So you got like a 15-year cycle, and the moment you walk to any investment house, you can see everyone looking up the sky and drinking more coffee than they ought to, because it's just not interesting enough. So we have the brunt of trying to convince them that this needs to be done. Well, COVID does help, but I'm sure as soon as the party starts, everyone will forget very quickly. But let's see how it goes. And then the regulation is not cohesive. I mean, we've got some really strange regulations with unintended consequences, issues like perverse incentives of fee for service. I think it's been mentioned there. Look, we understand the theory that you can't incentivize a doctor to over prescribe, but there is no counterbalance to a doctor who just sees you as his marketplace, right? So the counterbalance becomes the funder who can exert extraordinary amount of power, and all of this should have been succinctly defined in regulations, which kind of allows multiplicity of models. So effectively, we need ecosystems, and we don't need one ecosystem, we need many ecosystems. We are over reliant on one system, and it's driving away the equity capital to have creating 1 in 100 success stories, when this should, in most countries in OECD countries, healthcare is much more vibrant. People buying, selling, trading, changing models. Look, it's not perfect, but it's more vibrant. Here is the odd big group buying this one and the odd small group growing up, but it really needs to be a bigger and better place to be.
Thank you so much, Quinton. I'm sorry. Are you done with the presentation?
Yes.
Perfect. Thank you. Thanks so much. I really appreciated this view from a systems perspective, to see like what are the issues from a quite broad playing infrastructure player in the healthcare space. This is thank you very much for your valuable insights on that. We have the fourth speaker, and we are a bit behind time, unfortunately. Neveline Slinger. And I was actually really looking forward to your presentation, and I am looking forward to your presentation. Sorry about that. Neveline is the executive manager of social impact bonds at the South African Medical Research Council. She has experience working with many stakeholders and is interested in building innovative, transformative, and sustainable solutions. So I'm really looking forward to see how social impact bonds can be applied to the healthcare space. And especially from an institution like the Medical Research Council. I think that will be very interesting. The floor is yours.
Thanks. If I can just learn how to unmute myself. Thank you, everybody. Thanks for this opportunity. I think what I'm going to be talking about is slightly different. I'm from the South African Medical Research Council. I'm sure many of you might have heard and seen Professor Glenda Gray, who's our CEO and president, in talking about COVID-19 response and vaccines. The Medical Research Council is focusing on advancing life through research, innovation, and then transformation on many levels. I'm working in the unit called the Office of AIDS and TB Research. And what we've done is designed a social impact bond called the Imagine Social Impact Bond. And it focuses on adolescent girls and young women, 15 to 19 years in high schools. And we're doing this in 2 sub-districts in South Africa, one in the Northwest and one in KZN. The focus on adolescent girls and young women is about trying to make an impact on HIV and teenage pregnancy outcomes in this age group. I just wanted to give you an idea of the partners and the stakeholders and what we're focusing on. So we have the Department of Science and Innovation as our outcomes funder, and this provides its own particular challenges, bringing a government department as an outcomes funder. So the process of how this would work is that we have funding from the Science and Innovation as the outcomes funder. We have funding from an investor. The outcomes fund and the project account is managed by various people at the MRC. There's a governance structure to ensure a chain of command. Funding then goes to a lead implementer. We have quarterly an independent verification agent of data. And that once that report is approved by the outcomes funder and the investor, outcomes funding then flows from the outcomes fund account into the sub-project account, which then provides the ongoing funding for the implementation. The Medical Research Council is playing the intermediary role in this project. And just to mention that the upfront investment from the investor is 35 million rand. The outcomes that we're focusing on, I said we're focusing on HIV and teenage pregnancy. The proxy outcomes are sexually active adolescent girls and young women who are initiated on pre-exposure prophylaxis. That is obviously HIV negative girls. HIV positive adolescent girls and young women enrolled on antiretroviral therapy, those enrolled in contraception, and then those girls who are pregnant to attend antenatal clinic visits before 20 weeks. Obviously, these are just the proxy outcomes that are measured as part of the payment metrics, and there will be a lot more that's managed as part of the program, not only quantitatively, but also qualitative elements. The main aim here is to have the funding from the investor upfront until outcomes funding is earned by the achievement of the implementer of some of the targets set out in the proxy outcomes in the payment metrics. So there's a balance of risk between the private sector as well as the outcomes funder. We're trying to move to an outcomes-based contracting instead of fee for service or grant that government is most used to. The important element of the social impact bond is flexibility for the implementer in terms of responding to what they find on the ground, but also an improved management model. And the whole aim is obviously better outcomes and to achieve more than what current programs are being achieved. We also have value for money being provided, as well as we hope to attract investment for future social impact bonds through the lessons learned in this process. A few of the risk mitigation strategies from the beginning. There are challenging targets to mitigate perverse incentives. So which means we've set targets above what current programs are being able to achieve. We've selected an implementer who's experienced in service provision in this area, as well as the leadership and flexibility capability. Selected a geographical area where no other funders are working, and hence the results would be discrete. The social investor does a due diligence on the implementer, as well as the aspects of the program, the financial model, as well as the payment metrics targets. We are appointing an independent verification agent to provide a report on the data quarterly, as well as a performance manager who will proactively drive performance. There are firewalls between the decision makers for governance. This is a learning social impact bond. So we have split the outcomes funding between output and proxy outcomes in the payment metrics. To be able to respond to COVID-19 and its impact on schools, we are very closely aligned with the school term calendar. We're working with basic education and very closely with them to make sure that we respond to the continuing changes in their policies. And we're also always looking at alternatives, having different scenarios. The MRC as intermediary, there are a few challenges. Getting people to understand the financial model amongst the team is not necessarily easy because this is something new. We have a new process, so there are compliance challenges because there is no governance manual either at the MRC or at National Treasury. There's a lot of discussions about how to work this out. What are the regulations? How can they be interpreted in light of a social impact bond? Who needs to provide what approvals at what stage? There are special challenges with government as outcomes funder because they have many levels of approvals and you come into contact with a lot of bureaucracy. However, the MRC as intermediary also provides many opportunities. Because of their focus on health and innovation research and their link to policymakers, they have a clear idea of areas of need. They have access to the evidence-based package, and they also have access to the best sources of information in that particular area. And they're also able to call on people to make adjustments or do some further analysis of data from different sources if needed. The main challenges that we've come across are, first of all, the language and perspectives of different stakeholders. So you have an outcomes funder who is government, is used to doing something in a particular way and asking for particular kinds of results. They're not used to working with many other people. They normally just have a grant, which they give to an implementer, and they say, this is what I want. Now you have three people coming together, the outcomes funder, the implementer, and the social investor, and in fact, actually the intermediary as well, who each one thinks, well, comes with a different perspective, a different way of doing things, a different language. You know, the implementer and the MRC have a lot of acronyms that just roll off our tongues. And then sometimes an investor has the same acronym but means something completely different. So it's about understanding each other, working together, because you want to build trust and build this understanding and respect for each other, because everybody has a very important role to play. Another example is that the implementer is used, you know, they are working closely with the recipients of services. So they're working with people on the ground, whether it's in the school or the adolescent girls and young women or the community members around there. They want to be able to respond to the challenges or what is requested from the girls, but they're also very much aware of the fact that the social investor might be saying, but what is the risk in doing this? I want you to minimize the risk for me. Tell me what you're going to do beforehand and how you're going to do it. Whereas the implementer has to keep an open mind and be responsive to what they find. A second challenge is stakeholder relations and obtaining buy-in. I think once again, it is closely linked to the language, perspective, and culture of the different stakeholders. But here, you know, you have to acknowledge that what you're trying to do is use the strengths of each player. You're wanting to design the best plans together. Everybody has to understand what the opportunities and risks are for each person. While you're trying to work together, you're also learning together. So you need a lot of patience.
Nevelin, may I please ask you to wrap? May I please ask you to wrap up?
Sure.
We're trying to
sure.
bring this. Can you just go to your last point and then we can wrap up? Thank you so much.
Okay, no problem. My last point is just about the fact that this is something new, which means that investor needs to think about where's the funding coming from, the accounting structure and the tax treatment. And obviously this is all involved, this influences the contract that you'd have. And then also, what is the role of the social investor? What is their decision-making role in the process? Thank you very much.
Thanks so much, Evelyn. I'm sorry I had to interrupt you, because I would have loved to hear more about this. I think that social impact bonds are a fascinating topic, especially because they also bring investors a bit of diversification, and it's not all equity. So impact investment is not all direct equity in companies, which was the first three speakers. It also has other instruments, and one notable one is social impact bonds. So thank you very much for showing us a very complex topic in a very attractive and simple way. Thanks so much. So we move on to the breakaway rooms, and you all answer one question, and you have 10 minutes to do that. And the goal, please keep in mind the question that I asked you in the beginning as well, which is, what do we want to get out of this? What are kind of the next steps? So keep that in the back of your mind. And the questions that you've been asked by the organizers is to find a solution, or to discuss a solution to align demand and supply side of healthcare financing based on what you've been hearing from the panelists so far. So align the demand and the supply side of healthcare financing based on what we've been hearing so far from those four excellent presentations, and from the context that was also excellent before that. So I would there's a link Shiluba, do you want me to share? No, you shared the link. Perfect. So Shiluba shared the link to the Google Doc, so we can all work together on a Google Doc during the presentations. So I would ask Precious, I think, to start or Shiluba to start the break. Welcome back. I think we're still. Are we all back? Shiluba, are we all back?
I think so.
That's fantastic. All right. So thanks so much. We have to be a bit creative now because we're coming towards the end, and I just wanted to make sure that we all bring the inputs together that we harvested in those breakout rooms. I would suggest that we keep it as short as possible, and that we give it a bit more time than 5:30, and I hope that's fine with everyone, that we take another 5 minutes after the time. And that I would give it now to the first group to feedback in as short as possible.
Yeah, so I'm not sure who from group 1 would like to help me feedback. There was Lisa, Janice, and Marna. It looks like Lisa's keen.
So no, happy to do it in the interest of time. I think that's definitely great to have Vula Mobile's perspective in there as a demand side player and their challenges. And I think it's very much a blended finance approach was seen as a potential solution, which is not an easy solution, but really I think one that could be quite effective. And I think that's blended across the spectrum of investor types, but also across geographies. I think Saul's comment on the differences between South African and international investor types was very helpful. I think also what was an interesting insight, and maybe not a solution, but was also just the speed at which the technology, which is often what a lot of the demand side players are introducing, the speed with which technology is appreciated by supply side, often more in the public sector than the private sector. And that was a challenge. I don't know if there's any other points that I missed.
Marna, Janice, I don't know if you guys want to add anything to that.
I think it was a good summary.
Good, perfect.
Yeah,
thank you so much.
I thought that was good.
Then let's go to group number 2.
Yeah, I don't know if Frank, maybe you were going to speak, share our perspectives.
Yeah, sure. So I think one of the first things we spoke about the need for investor readiness. So the investees are speaking a language that's conversant and acceptable to the investors, but also on the investor side, especially in this time and age when you're trying to blend capital and be a bit more creative in how we mobilize capital, there's a huge need for innovative financing education amongst the investment community. So they can be a lot more comfortable with the variety of tools available to themselves with regards to how they can deploy capital, and also how they can tailor capital to different life cycle stages of the investees. So I think that would be really useful. I think coalitions to pool different types of funding, and especially, I think, in my view, grant capital so that it can be used in a catalytic manner to de-risk social investments and some of these investments and provide concessional capital. We're seeing a lot more pooled funding, for example, happening in Asia. I think we could benefit from something like that in Africa. Patient capital has been mentioned. Glossary of terms just to align how we talk across each other, especially between the development and private sector, is important. Non-financial capital, it's not always about money. I think we need to be cognizant of the fact that there is a need for other types of support like M&E and impact measurement. I think the issue around strengthening value chains, it's amazing how when you bring these investees together, they find ways to plug each other's holes, and finding that platform where they can connect is important. And then how do we quantify social impact? What does it mean for us? How do we offer equitable access to some of these innovations so that the innovations are not stuck in Santon and they don't reach where they're most needed?
Thank you so much, Frank. Thanks for that succinct salary. I appreciate this in the interest of time. We're coming to the third group.
So Beth is going to share from the third group. Go ahead, please, Beth.
And also in the interest of time, I'll try not to repeat points that the other groups have made. I mean, I guess
that's appreciated. Thanks.
Some of the key things that came out is standardized approach to outcomes reporting. I mean, it was mentioned by Frank earlier, but we think it's important that you have key indicators against which we can report and everyone starts talking the same language. creative ideas about how to bring demand and supply side together. I think Neveline obviously talked about the kind of philosophical and language differences that exist, and it's good to get sort of projects identified that parties can work on together to start that journey of understanding. And in terms of that, sort of focus on the priority areas, and then how to track service delivery and impact as a starting point in those areas, because it's a massive ecosystem that we're trying to impact. And so it's good to have a sensible place to start.
Fantastic, Beth. This is getting shorter and shorter. I love it. And then thank you so much. And then the fourth group, we had 4 groups, right?
No, we just had 3 groups.
Oh, fantastic. Oh, that's even better. Good. All right. So let me wrap up then, and maybe then hand over to Sawa with a couple of suggestions. So I clearly saw, like, thanks very much for participating, everyone. I think this has really been a very insightful, super dense 90 minutes, and you can see the ambition of the organizers to get all this through in such a short period of time. And I think we all did a fantastic job to get there. I wanted to maybe highlight 3 points that I picked up from that feedback, or 3 topic areas that could be considered for further further action within the committee. I think the first one is about investment structure, and see how, more on a technical side, to see how blended finance, the use of grants, the building of coalition of different financiers to create a blended finance structure, and the use of patient capital also on the commercial side, in order to grow businesses that actually are able to compete within a South African environment, and that have more of an impact lens than what maybe is existing at the moment. So I think the first one would be around structure. The second one, and convening people to then create that structure, that would be kind of the what's coming from that. The second one is about language and mindset, and that obviously underlies that collaboration. And I think there have been many good suggestions about glossaries, around other things. Maybe it could be also industry insights that could be published that explain a bit what the challenges are, and explain it in a language that health practitioners as well as investment practitioners can understand. So the idea of bringing language and mindset together, I think would be a very useful activity for the impact investing task force going forward. And this was the second point that I picked up. And the third point is a thorny one, but I think is an important one, around M&E and standardization of impact metrics. And in healthcare, obviously there are many different approaches how to do that, but I think there are a couple of clear ones that could be used, that they come out of medical practice, and that can be used as impact strategy, to use those impact metrics across different players, I think, and do seminars or forums that allow to kind of find the common language across different investors, and how to measure impact in health could be a third area of activity of the task force. So this is the 3 tasks that I see the participants giving to you, Sawa, and I will hand the word over to you as well, and wish you a great evening. Thanks so much.
Thank you, Pascal, so much for graciously moderating this wonderful session today. I'm just really grateful for all of the deep insights that we have received, and I've been taking furious notes that I'm sure many of you have been doing. I'd like to perhaps suggest that I circle back with the Bertha Center team and sort of try to figure out what the next steps may be. Our idea originally was to have a series of different sector sessions, but it's also a great shame not to proceed on some of the insights and ideas and solutions that came out of this particular session, and we can possibly create some other kind of subgroups or other initiatives that could emanate from this. So any other suggestions from yourselves, feedback are very much appreciated. I think you know where to find us. So I just want to conclude with just a huge appreciation for the panelists, for the moderator, and for the participants for this very active session. I really enjoyed it immensely. It's a first of its kind, and there will be many more to come. Thank you so much for your time.
Thank you so much, Sarah. I think that concludes the session for today. We will share next steps in an email and following some of the feedback as Sarah discussed and next steps. Thank you so much again for everyone who has joined and for your participation. Really appreciate it. Enjoy your evening. Bye.
Thank you, Shaluba.